any financial disclosures. This is an 80-year-old gentleman who was referred to me for OM CTO PCI. Several months ago, he presented to another hospital with unstable angina, small non-STEMI. Cath there revealed a patent Lima to LAD, patent SVG to RCA, an occluded sequential SVG to OM1 and OM2, and then there's the OM CTO with a proximal ambiguous cap. Despite attempts at medical therapy, continues to suffer with class 3 angina. He's on good anti-anginal therapies. His physical exam is unremarkable. EF is normal. His MPS confirms high-grade ischemia in the circumflex territory. This is an angiogram of the native left coronary artery. You can see that AV groove circumflex without any obvious obtuse marginals, so the proximal cap, in my mind, was ambiguous. This is an angiogram of the Lima to the LAD. You will see some late filling to the OM1 and 2, which are still connected by a sequential remnant of the old bypass graft here. This is an angiogram of the Sactus vein bypass graft stump. Although it does not appear favorable, in my mind this was a primary retrograde case, and my only retrograde option was the occluded Sactus vein bypass graft. So I penetrated the proximal cap of the vein graft using a Confianza Pro 12 and chased that with my turnpike microcatheter. I then de-escalated to a radar wire, which I was able to drill all the way down the graft into the OM. I then chased that with the turnpike microcatheter and then de-escalated further to a workhorse Xi'an blue wire, which I was able to navigate through the remnant of the vein graft and then up the second OM towards the distal cap of the CTO. I chased that with the turnpike microcatheter and then switched back to my radar wire and tried to cross the CTO retrograde, but I got stuck at this location. At this point, I used the just marker technique, used a Confianza Pro 12 to aim towards my retrograde gear. I was able to achieve overlapping wires here, but my antegrade wire was not moving freely, so I know it was in the subintimal space, but I felt I was in a good place here to perform reverse cart. But when trying to advance my balloon here, I had a difficult time getting it through the proximal cap of the CTO, and during those efforts, I actually lost wire position. When I rewired, the only place I could get it is here, in this area here, which I imagined was a small branch artery. I decided to try reverse cart proximal to the splaying of the wires, but unfortunately my balloon shot forward as I inflated it, watermelon seated forward, and this concerned me. I performed an angiogram right away and confirmed this LS3 perforation in the obtuse marginal. Very quickly, I inflated a balloon proximally. Despite performing several prolonged balloon inflations proximally, the perforation persisted as demonstrated here. To take control of the situation very quickly in this elderly patient who I thought has very little reserve, I wired the AV groove circ and deployed a papyrus stent across the origin of that obtuse marginal to seal off blood flow to the perforation. There was no residual perforation visualized on the next angiogram. By this time, my echo tech had arrived to my cath lab. We performed a stat echo. There was actually no significant pericardial effusion. The patient remained hemodynamically stable through all of this. Whenever this happens to me, I don't like to rush patients out of the lab, and I keep them in the lab another 20, 30 minutes to make sure nothing bad is going to happen. During that time, I got impulsive and thought maybe I can help this patient's angina by opening his bypass graft. I did this by opening with a laser atherectomy, 0.9 millimeter catheter set at 40 and 40. I lasered across the graft. I performed penumbra thrombectomy using a CAT-RX to remove any atheroembolic debris. Then I performed IVUS-guided stenting of the bypass graft and actually got a good result. The patient left the hospital the next day pain-free, but I was concerned about the long-term durability of this result, and I specifically educated the patient about coming back and letting us know if he develops any recurrent anginal symptoms. 6 months actually went by. He had a recurrent presentation with unstable angina about 6 months later, small non-STEMI, and this was his angiogram of the bypass graft. It's actually widely patent. The distal vessel has remodeled positively, and actually interestingly, he was symptomatic because of restenosis at the papyrus site in the AV groove circ. That was treated with a drug-eluting stent. Patient's been pain-free since then. We're now about 6 months after this drug-eluting stent. In conclusion, due to poor expected durability and increased procedural risk, recanalization of chronically occluded SVGs is generally discouraged. Nevertheless, there may be rare situations in some elderly patients like this in which SVG CTO PCI leaves us with the only option for symptom relief and may provide sufficient durability in elderly patients who have poor overall limited life expectancy. If the techniques used in this case to recanalize the chronically occluded SVG are found to be reproducible, they may provide us with additional treatment options in this challenging subset of patients. A few comments about the technique I used in the vein graft. When I was performing laser atherectomy, I intentionally did not inject any saline while I was performing laser. There was no outflow, and I did not want any atheroembolic debris to backflow into the aorta and embolize the brain and cause a stroke. Also, I intentionally did not treat the last 10 to 20 millimeters of the occluded bypass graft until the very end of the procedure. What I mean by that was I initially performed laser just shy of the last 10 to 20 millimeters, performed thrombectomy, performed IVUS and stents, using that very distal part of the occlusion as a distal embolic protection device. Then I performed one more thrombectomy run, one more laser run of that occlusion, and then directly stented that last area. Thanks for your attention.